Bismillahirrahmanirrahim. Quote of the day. Remember, when you forgive, you heal, and when you let go, you grow. Today, the topic of my presentation is antenatal care, and I'm presenting it under supervision of my professor, Dr. Tata. Learning outlines of my presentation are introduction, objectives, antenatal visits, antenatal checkups, warning signs, specific protection, recent updates, and MCQs in the end. Learning objectives. At the end of the presentation, the participants will be able to describe the objectives, essential components, and needs for better antenatal period. Now, what is antenatal care? It is the care of the woman during pregnancy. The primary aim of antenatal care is to achieve at the end of a pregnancy a healthy mother and a healthy baby. Ideally, this care should begin soon after conception and continue throughout the pregnancy. The objectives of antenatal care are to promote, protect, and maintain the health of mother during pregnancy, to detect high-risk cases and give them special attention, to foresee complications and prevent them, to remove anxiety and dread associated with delivery, to reduce maternal and infant mortality and morbidity, to teach the mother elements of child care, nutrition, personal hygiene, environmental sanitation, to sensitize the mother to the need for family planning, including advice to cases seeking medical termination of pregnancy, to attend to the under fives accompanying the mother. Now, quality throughout the continuum of care. WHO recommendations on antenatal care for positive pregnancy experiences that it envisions a world where every pregnant woman and newborn receives quality care throughout the pregnancy, childbirth, and the postnatal period. It prioritizes person-centered health and well-being, reducing mortality and morbidity, providing respectful care that considers women's views, optimizing service delivery within health systems. Now, what are women's views? Women want a positive pregnancy experience from antenatal care. These are a healthy pregnancy for mother and baby, including preventing or treating risk, illness, and death, physical and social culture normality during pregnancy, effective transition to positive labor and birth, positive motherhood, that is including all predators, self-esteem, competence, and autonomy. Antenatal visits. 2016 WHO antenatal care model. First, there was antenatal care model which was introduced by WHO in 2002, and it consisted of total 4 visits. That is first visit in the first trimester, that is at 8 to 12 weeks, and then the second visit in second trimester at 24 to 26 weeks, and 2 visits in the third trimester, that is third visit at 32 weeks, and the last visit or fourth visit at 36 to 38 weeks. But then it was replaced by the 2016 WHO model, which consisted of 8 visits. The antenatal care models with a minimum of 8 contacts are recommended to reduce perinatal mortality and improve women's experience of care. So this is the 2016 WHO ANC model. In first trimester, there is a first visit that is up to 12 weeks, and then second trimester, there should be 2 visits, that is at 20 weeks and 26 weeks, and the other 5 visits should be in the third trimester, that is at 30, 34, 36, 38, and 40 weeks, that is at the period of every 2 weeks. Previously, as I've already told you, that there were 4 visit WHO ANC model. It involves specific evidence-based interventions for all women. It carried out at 4 critical times, also known as the focused antenatal care model, and was a part of pregnancy, childbirth, postpartum, and newborn care. Now, this most pregnant women assess skilled antenatal care at least once, but globally only 60% receive 4 antenatal care visits. So these are the percentages of women aged 15 to 49 who attend at least one, that is ANC 1, and 4 antenatal care visits with any of their providers. So these are the percentages showing in different regions of the world. Then comes Pakistan. The lowest levels of antenatal care are observed in sub-Saharan Africa and South Asia. With Pakistan, there is 51% of women aged 15 to 49 were attended by any provider at least 4 times during their pregnancy. That is, they have 4 visits. This is the percentage of Pakistani women, 51%. So this green color shows the 60 to 80% of women getting 4 visits. The summary of these maps is that globally, while 87% of pregnant women access antenatal care with a skilled health person at least once, less than 3 in 5, that is 59%, receive at least 4 antenatal care visits. In regions with the highest rates of maternal mortality, such as Western and Central Africa and South Asia, even fewer women receive at least 4 antenatal care visits, that is 53% and 49% respectively. Early pregnancy detection. It facilitates proper planning and allows for adequate care to be provided during pregnancy for both the mother and fetus. It records the date of last menstrual period and calculates the expected date of delivery. The health status of mother can be assessed, and any medical illness that she might be suffering from can be detected. Also, to obtain and record the baseline information on blood pressure, weight, and hemoglobin. Also, it helps in timely detection of complications at an early stage and helps to manage them appropriately by referral as where required. Early detection of pregnancy and provision of care from the initial stage facilitates a good interpersonal relationship between the caregiver and the pregnant woman. Preventive services for mothers. Essential components of every antenatal checkup are to take the patient's history, conduct a physical examination, measure the weight, blood pressure, respiratory rate, and check for pain and edema. Conduct the abdominal palpation for fetal growth, fetal life, auscultation of fetal heart sound according to the stage of pregnancy. Carry out laboratory investigations such as hemoglobin estimation, urine test for sugar and proteins. So history taking includes that is confirming the pregnancy at the first visit only, then identify whether there were complications during any pregnancy, identify any current medical, surgical, or obstetric conditions, record the date of first day of last menstrual period, record symptoms indicating complications, fever, persisting vomiting, abnormal vaginal discharge or bleeding, history of any current systemic illness, hypertension, diabetes, heart disease, tuberculosis, family history of congenital disease, and the last is history of drug allergies and habits. Physical examination, it all includes that pallor, presence of pallor indicates anemia, pulse, which should be in the range of 60 to 90 beats per minute. Respiratory rate, it is important to check it as, especially if the woman complains of breathlessness. Edema, swelling, which appears in the evening and disappears in the morning after a full night's sleep, could be a normal manifestation of pregnancy. Any edema of face, hands, and abdominal wall and is abnormal. Blood pressure. Measuring the woman's BP at every visit to rule out hypertensive disorders of pregnancy. Hypertension is diagnosed when 2 consecutive readings taken 4 hours or more apart show the systolic blood pressure to be 140 mmHg or more and a diastolic BP to be 90 mmHg or more. High BP during pregnancy may signify pregnancy-induced hypertension or chronic hypertension, and the presence of albumin, that is +2 or more, together with high BP is sufficient to categorize her as having preeclampsia. Weight. A pregnant woman's weight should be taken at each visit. The woman taken during the first visit, weight taken during the first visit should be treated as the baseline weight. Normally, a woman should gain 9 to 11 kg during her pregnancy. Ideally, after the first trimester, a pregnant woman gains around 2 kg every month. Abdominal examination. Examine the abdomen to monitor the progress of pregnancy and fetal growth. The abdominal examination includes the following. First is measurement of fundal height. It is the enlargement of uterus, and the height of the uterine fundus is as shown that at 12 weeks it should be up to pubic bone. Then at 22 weeks it should be at the level of umbilicus, and at 36 weeks ideally it should be at the level of xiphi sternum. Then comes fetal heart sounds. It can be heard after 6 months. The rate varies between 120 to 140 per minute. They are usually best heard in the midline after the 28th week. However, their location changes because of the position and lie of the fetus. Then comes fetal movements. They can be felt by the examiner after 18 to 22nd week by gently palpating the abdomen. Fetal parts, they can be felt about the 22nd week. After the 28th week, possible to distinguish the head, back, and legs. Multiple pregnancy. This must be suspected if the uterus is larger than the estimated gestational age or palpation of multiple fetal parts. Fetal lie and presentation. It is relevant only after 32 weeks of pregnancy. Then comes inspection of abdominal scar or any other relevant abdominal findings. Assessment of gestational age. Measurement of gestational age has changed over time. The most accurate gold standard for assessment is routine early ultrasound assessment together with fetal measurements, ideally in the first trimester. Gestational age assessment based on the date of last menstrual period was previously the most widespread method used and remains the only available method in many settings. Many countries now use best obstetric estimate combining ultrasound and LMP as an approach to estimate gestational age. Then anomaly scan. It is used to detect any unusual development of developmental finding, and it is usually recommended at 18 to 20 weeks of gestation. Then comes laboratory investigations. The following laboratory investigations are carried out at the facilities indicated below. At the BHU, it is pregnancy detection test, hemoglobin examination, blood group, including RH factor, urine test for presence of albumin and sugar, rapid malaria test, dengue, and blood pressure testing, blood sugar testing. Then at the RHC, DHQ, or THQ level, it is HIV testing, rapid malaria test, if it is unavailable at BHU. Then hepatitis B as antigen for hepatitis B infection. Interventions and counseling. It includes iron and folic acid supplementation and medications as needed, immunization against tetanus, group or individual instruction on nutrition, family planning, self-care, delivery and parenthood, home visiting by a female health worker trained diet, and in the end referral services where necessary. Prenatal advice. It consists of diet and reproduction cost energy. A pregnancy in total duration consumes about 60,000 kilocalories over and above normal metabolic requirements, and lactation demands about 550 kilocalories a day. So, our total calories per day needed by a pregnant lady should be around 2000 2580. And these are the different portions of the sodium, carbohydrate, protein, irons, total fats, and calcium. And these are the recommended quantity of these in personal hygiene. Personal cleanliness, rest and sleep, 8 hours sleep, and at least 2 hours rest after midday meals. Constipation should be avoided by regular intake of green leafy vegetables, fruits, and extra fluids. Light household work is advised, but manual physical labor during the late pregnancy may adversely affect the fetus. And smoking, alcohol, these should be quit during pregnancy, and there should be a special attention on the dental care. Then comes drugs radiation. Drugs must be taken with caution and with advice of doctor. The X-ray examination in pregnancy should be carried out only for definite indications. Warning signs. The mother should be given clear-cut instructions that she should report immediately in case of following warning signs like fits, convulsions, severe headache, blurring of vision, severe bleeding or discharge from vagina, and persistent vomiting, severe abdominal pain, persistent back pain. Specific health protection. First comes anemia. The major etiological factors being iron and folic acid deficiencies. It is well known that anemia per se is associated with high incidence of premature births, postpartum hemorrhage, puerperal sepsis, and thromboembolic phenomena in the mother. Daily oral iron and folic acid supplementation with 30 milligrams to 60 milligram of elemental iron and 400 microgram, that is zero point 0.4 milligram folic acid, is recommended for pregnant women to prevent maternal anemia, puerperal sepsis, low birth weight, preterm birth. Women already having child with spina bifida must take 4 milligram of folic acid daily. Then comes toxemia of pregnancy. The presence of albumin in urine and an increase in BP indicate toxemia of pregnancy. Their early detection and management are indicated. Efficient antenatal care minimizes the risk of toxemias of pregnancy. Then comes tetanus. If the mother was not immunized earlier, 2 doses of adsorbed tetanus toxoid should be given. The first dose at 60 to 20 weeks and the second dose at 20 to 24 weeks of pregnancy. Syphilis. Screen all pregnant women for syphilis with on offsite RPR or other available rapid tests at the first antenatal visit. Screening should be done preferably before 16 weeks of gestation to prevent congenital infection and again in the third trimester. Then comes German measles. It must be considered if there is history of contact or symptoms. Recommended vaccines during pregnancy. CDC recommends that pregnant women get 2 vaccines during every pregnancy. First is flu vaccine that is inactivated. CDC recommends getting the flu vaccine if a lady is pregnant during flu season. While flu seasons varying in the timing, CDC recommends getting vaccinated by the end of October if possible. Then comes Tdap vaccine. Pregnant women are encouraged to get it at any time during pregnancy, but optimally between 26 and 36 weeks of each pregnancy to protect herself and her baby from pertussis, also known as whooping cough. The vaccine is recommended during every pregnancy, regardless of how long it has been since she previously received the Tdap vaccine. So these are the vaccines for pregnant women. The recommended vaccines are influenza inactivated. Remember that live attenuated vaccine of influenza vaccine is contraindicated. Then comes hepatitis A, B. It is recommended if other high risk conditions are present. Then comes Tdap. So I've already told that optimal administration should be between 26 and 30 weeks of gestation during each and every pregnancy, regardless of prior Tdap vaccination. And HPV and pneumococcal vaccines are not recommended. However, this varicella and zoster, these vaccines are contraindicated. Then comes mental preparation. Antenatal care does not mean only palpation, blood and urine examination, and pelvic measurements. These are no doubt important aspects of antenatal care. Mental preparation is as important as physical or material preparation. Family planning. Family planning is related to every phase of the maternity cycle. The mother is physiologically more receptive to advice on family planning than at other times. Education and motivational efforts must be initiated during the antenatal period. Advice with pets at home. It is generally safe to have a cat while a lady is pregnant, like dogs, but they should be must watch out for bites, scratches, and decks. But with cats, she must be careful about dealing with cat poops, cat feces, as cat feces can contain the parasite that cause toxoplasmosis. Now, coming on to recent updates. This is an article implementation of the new WHO antenatal care model for positive pregnancy experience, a monitoring framework. According to it, the new WHO antenatal care model, for example, iron, folic acid supplements, ultrasound scan before 24 weeks, and antihelminthic treatment, and other recent recommendations like syphilis testing, counseling on pregnancy danger signs fit into this framework. The model aims to achieve maternal outcomes like infection, side effects, and symptomatic relief, fetal neonatal outcomes, that is preterm birth, congenital abnormalities, and low birth weight, test accuracy outcomes in terms of sensitivity and specificity, and health system outcomes, that is antenatal care coverage and facility-based delivery. These outcomes of interest guided the development of the new WHO antenatal care model and provide clarity on what the monitoring framework's impact domain means for antenatal care. This is in another article on special considerations in pregnancy with regard to COVID-19. According to it, pregnant people should be concerned about the increased risk for severe disease from SARS-CoV-2 infection. If hospitalization for COVID-19 is indicated for a pregnant patient, care should be provided in a facility that can conduct maternal fetal monitoring. Management of COVID-19 pregnant patients should include fetal and uterine contraction monitoring based on gestational age when appropriate, individualized delivery planning, multi-speciality team-based approach that may include consultation with obstetric, maternal fetal medicine, infectious disease, pulmonary critical care, and pediatric specialists as appropriate. In general, the therapeutic management of pregnant patients with COVID-19 should be the same as for non-pregnant patients. Pregnant or lactating patients with COVID-19 and their clinical teams should discuss the use of investigational drugs or drugs that are approved for other indications as treatment for COVID-19. The decision to feed the infant breast milk while the patient is receiving therapeutic agents for COVID-19 should be collaborative effort between the patient and clinical team, including infant care providers. This article titled as Factors Affecting the Utilization of Antenatal Care Among Married Women of Reproductive Age in Rural Tata, Pakistan. These are the findings from a community-based case control study. According to it, a community-based case control studies was conducted in Tata district, Pakistan, and women who did not utilize antenatal care services during their last pregnancy were considered as cases, while controls were women who utilized antenatal care services during their last pregnancy. Questions related to their demographic factors and utilization of antenatal care were asked from women. And road network distance was calculated from the woman's home to the healthcare facility providing antenatal care services. And so the conclusion was that road network distance has no measurable impact on antenatal care utilization among married women in Tata. Nulliparous women having knowledge of antenatal care living in well-constructed houses equipped with electricity were found to be utilizers of antenatal care services. So it is recommended that awareness and health education sessions should be arranged for pregnant women in rural Pakistan. COVID-19 in pregnant women case series. According to it, there were 26 COVID-19 positive pregnant women were taken in this study. And out of these, 10 were asymptomatic, and among symptomatic, 14 were suffering from fever, and 11 were having cough. And there was a one case of severe pneumonia. So of the 14 women delivered, 11 had cesarean section. However, there were no cases of miscarriage, spontaneous preterm labor, intrauterine demise, neonatal death, or vertical transmission of COVID-19. So conclusion was that majority of pregnant women with COVID-19 suffered mild disease. Pregnancy did not appear to aggravate or change the course of COVID-19, nor did COVID-19 appear to increase the risk of obstetric complications. Now coming on to MCQs. MCQ number 1. A lady who is pregnant or considering pregnancy should get a health checkup. Which of these vaccines should be up to date before they get pregnant because of the danger of the disease to the fetus? A. Tetanus. B. Diphtheria tetanus. C. Measles, mumps, rubella. D. Flu.
A.
B is the more appropriate option. MCQ number 2. A 21-year-old woman presents in OPD for her routine antenatal checkup at 22 weeks gestation. Where would you expect to find the uterine fundus? Pubis, umbilicus, xiphisternum, halfway between xiphisternum and umbilicus.
Umbilicus.
B.
Yes, B is the right option. MCQ number 3. A 27-year-old pregnant lady comes to see you. She tells you that it is her first pregnancy and the last time she saw her menstrual period was 25 weeks ago. What would you normally see her for the next visit? A. 26 to 28 weeks, 30 to 32 weeks, 34 to 36 weeks, 36 to 38 weeks.
B. 30 to 32 weeks.
Yes, B is the right option, 30 to 32 weeks, according to 2016 WHO ANC. MCQ number 4. Suppose a young lady comes to you at 32 weeks of her pregnancy. You discover that her blood pressure is 120 per 90 mmHg. She has mildly male conjunctiva and fundal height is measured as the 38-week size. What would be the possible reason for this fundal height? Oligohydramnios, preeclampsia, twin pregnancy, history of smoking in mother.
C.
C.
Yes, C is the right option. Yes. MCQ number 5. A 37 weeks pregnant woman attends an antenatal clinic at a primary health care. She has not had any antenatal visit till now. The best approach regarding tetanus immunization in this case would be A. Give a dose of tetanus toxoid and explain to her that it will not protect the newborn and she should take the second dose after 4 weeks even if she delivers in the meantime. B. Do not raise the tetanus toxoid vaccine as it would anyhow be of no use in this pregnancy. C. Give one dose of tetanus toxoid and explain that it will not be useful for this pregnancy. D. Give her anti-tetanus immunoglobulins along with the tetanus toxoid vaccine.
A.
Yes, A is the right option. MCQ number 6. Healthcare providers advise people to take 400 microgram of folic acid daily. Yes, daily before they get pregnant and during pregnancy. What can this help prevent in the baby? Respiratory distress, blood disorders, brain spinal defects, congenital.
C.
Yes, C is the right option. MCQ number 7. A disease contracted from a parasite found in cats can cause severe damage to an unborn child if the mother becomes infected. This disease is rubella, toxoplasmosis, German
Plasmosis.
flu.
B.
Yes,
B.
C is the right
Toxoplasmosis.
option. Yes. MCQ number 8. A 35-year-old woman who is now in her fifth pregnancy while 4 live children presented in the antenatal care and is diagnosed as a case of anemia. She consumes green leafy vegetables and foods, but her diet is deficient in meat products. Cause of anemia in her case is folate deficiency, sickle cell anemia, iron deficiency, thalassemia.
C.
Yes, C is the right option. 9. A 19-year-old primary gravida comes in emergency at 32 weeks of gestation. She is complaining of blurring of vision, gross edema. On examination, her BP is 170 by 115 mmHg. What is the most likely diagnosis? Hypertension, renal disease,
D.
eclampsia, preeclampsia, thyroid disease.
D. Preeclampsia.
Yes,
C.
yes, C is the right
B.
option. Yes.
Preeclampsia.
Because her raised BP is also associated with edema. That is, it is showing loss of protein. So it is the characteristics of preeclampsia. MCQ number 10. A 23-year-old primary gravida presents to you at 14 weeks of gestation. She is concerned about normality of fetus. At what time you will advise her detailed fetal anomaly scan? 22 to
C.
24 weeks.
24 weeks.
C. 18 to 22 weeks.
C.
The right option.
Alpha.
C is the right option. 18 to 22 weeks. This is the key of MCQs, and thank you.
Okay, thank you very much, Dr. Meha. It is a wonderful presentation. And after vacations, what I have seen that everybody has worked very hard on their learning and for their own development. The most important thing about MCH is that it is a very important topic as far as our community is concerned, prevention is concerned, and examination. I would like to ask one important question. What is the Kish grid method? Anybody from the class could elaborate what is the Kish grid method? Okay, it is a very important method for the household random sampling. Whenever you go to different households, there are different methods of sampling that can be done because we know that the mother and the children, they are two important part of the family that can be missed whenever the population is approached for any research. Those who are very active, especially those who are answering at the doors, they are the one who are getting sampled. So in order to reduce this sampling bias, one of the very important method is cash grid method, especially in our context. In other countries, other methods are also used, like last birthday method, first birthday method, etc. However, in Pakistan, we have seen that if we want to sample the mother and children in our research, we must go for the cash grid method. First, the grid is constructed where all the members of the household, including the mothers and children, they are put in certain order from the youngest to the oldest. You can say that this has given more weightage to the youngest of the family, yes, in order to avoid the missing of the children from the sampling. We would list the children first. After that, the random sampling is being done. So it is important for having the evidence and research to be taken place, especially where mother and child health issues are concerned. Very nicely presented, and there are no questions in the chat box, so we can stop here. Allah Hafiz. See you
Thank you,
next time.
ma'am. I love this.